So, vulvar cancer. Vulval cancer is a rare malignancy of the female genital tract. It represents less than 5% of all gynecological cancers. It has a high mortality rate, not because the tumor is particularly aggressive, but because early diagnosis is very rare. So, early diagnosis is very rare. Diagnosis is usually late due to clinical manifestations of the malignancy due to symptoms, due to patient's characteristics, due to lack of awareness of clinicians in terms of identification of vulval cancer in unsuspected settings. Histology: 85% of cancers of the vulva are squamous. Melanoma of the vulva is quite frequent type, 5%. You also have stromal tumors growing in the external genitalia area, that is, sarcomas, representing 2%, and we have a higher proportion compared to cervix of other histological types. Melanoma is very interesting in terms of natural history, in terms of treatment option and staging. Another subset of vulvar cancer is represented by Paget's extramammary disease. It is a frequent observation in older patients and in general has a benign course. 10% of cases, Paget's disease will be invasive and it can be associated with adenocarcinoma of the vulva for 8% of cases, or of the rectosigmoid distal colon. So in case of Paget's vulvar disease, another tumor of the pelvis must be excluded with a comprehensive diagnostic workup and a very precise diagnostic mapping of the disease must be performed to exclude the presence of invasive disease. Paget disease is not easily recognized clinically. It can present as a dystrophic, reddish, possibly hypertrophic and hyperkeratotic lesion, but no evident signs of malignancy are clearly detectable. In other cases, small reddish erosions of the superficial layers of the skin are present on the genital area and also on the perianal and perineal area. These erosive lesions are the most suspected for invasion and for the presence of an adenocarcinoma underlying a superficial aspect of Paget's disease. Then, possible presentations include isolated bleeding sites and ulcers. So, Paget disease is not easily recognized clinically, can present as dystrophic reddish, possibly hypertrophic and hyperkeratotic. And multiple biopsies are needed to make a comprehensive diagnosis. So we need what is called mapping of the lesion to exclude or confirm the suspect of invasion. So let's repeat, the vulvar cancer can be classified into squamous cell carcinoma, 85% of cases, melanoma 5%, sarcoma 2%, or others in 8% of cases. Epidemiology: vulvar cancer has a biphasic age distribution, an early onset of the disease in the age group of 40-50 years, and another peak of incidence in older patients, around 70 years. The first peak is strictly correlated with HPV. The second one is more frequently related to chronic inflammatory conditions and vulvar dystrophic skin diseases. Also, other sexually transmitted diseases like syphilis, granuloma inguinale, and lymphogranuloma venereum are associated to early onset of vulvar cancer. Tobacco smoking, as for cervical cancer, is another risk factor for HPV-related vulvar cancer. Symptoms: in general, vulvar cancer patients are treated for other conditions first, and this is the reason why diagnosis is delayed for a long time. That is, more than 12 months, and early diagnosis is impossible. The long-lasting presence of symptoms treated for other reasons delays the histological diagnosis and reduces the possibility of early-stage diagnosis. Symptoms are very aspecific. Pruritus is one of the most frequent. and is quite easily treated aspecifically by general practitioners or by patients themselves. Presence of a mass is more correlated with early diagnosis. Pain, bleeding, ulcerations, genitourinary symptoms like dysuria, vaginal symptoms like discharge, or growing metastatic disease presence can all be present in vulvar cancer. So we can have also pain, bleeding, ulceration, genitourinary symptoms, vaginal symptoms. The elementary lesion of a vulvar cancer is the same as in every other skin region. So, as a skin tumor, it can be raised, erythematous, ulcerated, condylomatous, nodular, or like other dermatological elementary lesions suspected for a malignancy. So it can be raised, erythematous, ulcerated, condylomatous, or nodular. The key point is to always indicate a biopsy in the case of an abnormal, atypical appearance of the vulvar um, surface. The semiotic clinical diagnosis is almost impossible. You can have a very small erythematous area and a tumor underneath. A persisting lesion that is more than 2-3 weeks of topical steroids with no resolution must be submitted to histological evaluation since the risk of a tumor is very high. The only way to reach diagnosis of vulvar cancer is performing biopsies. Many cases, multiple biopsies, especially in presence of large extension of gross abnormality or gross abnormalities. Staging. The tumor spread is very quick. Early stages of vulvar cancer are associated with lymph node metastasis. They directly spread firstly to the groin. Superficial inguinal femoral nodes are the first metastatic sites of vulvar cancer. So, the superficial inguinal nodes are the first metastatic sites of vulvar cancer. As a second-line spread, we have hematogenous dissemination with distant metastasis. Staging is clinical and based on size, node status, and presence of metastatic diseases for cervical cancer. We have stage 1, which is less than 2 centimeters in linear extension. We have stage 1A, which is less than 1 millimeter depth of invasion. Stage 1B is more than 1 millimeter depth of invasion. Stage 2 is more than 2 centimeters in linear extension, but limited to the vulva or external perineum. Stage 3 is any size of the tumor, also less than 2 centimeters, with involvement of lower urethra of the vagina, of the anus, or with unilateral superficial inguinal nodes involvement. Then we have stage 4, which is subdivided into A and B. Stage A is any tumor size with involvement of upper urethra or inside of the bladder, the rectum, of the pelvic bones, or with bilateral superficial inguinal nodes involvement. Stage 4B is presence of distal metastasis, including deep pelvic nodes involvement. Treatment is primarily surgical, even for very large tumors. The help of a plastic surgeon may be needed for the reconstructive part after wide excisions. We have the option of performing wide local excisions in the case of early stage cancer, stage 1 and 2. We have the need to perform radical vulvectomy with inguinal node dissection in the case of extended disease. Treatment is dependent on nodal status. If a distant local nodal metastasis is detected, an adjuvant radiation therapy is indicated, external radiotherapy of the bilateral inguinal area and perineum. We have special histological types. Firstly, the verrucous carcinoma, which is prognostically bad in appearance but instead is favorable in prognosis according to the biological history. So a verrucous carcinoma has a very low probability of giving distant metastasis and lymph nodal metastasis. It can be huge in dimensions but very easily removable by wide surgical excision with an optimal prognosis. In rare cases, when radiotherapy is used for this tumor, the natural history of the disease changes dramatically, and under the effect of radiation therapy, the verrucous carcinoma becomes more malignant and more aggressive, with a higher recurrence rate, but this in rare cases. So, repeat, treatment is primary surgical. We can use wide local excision or radical excision or radical vulvectomy with inguinal node dissection. It can be unilateral, bilateral, and possible node mapping still investigational. Local advances may be treated with radiation plus chemosensitizers, and in case of positive nodal status, we can have 1 or 2 microscopic nodes of less than 5 millimeters can be observed, or 3 or more than 5 millimeters post-operative radiation. Anyway, survival, well, very good for early stages, very bad for late stages. Recurrences are mainly local, and so second surgery with re-excision or radiation of the disease is easily performed. In case of recurrence of the disease in the same original site of primary tumor, the prognosis is poor. If the site of recurrence is in a secondary site, distant from the primary tumor, the prognosis is better. So if it's the same site, poor prognosis. If it's distant site, better prognosis. Distant metastases are associated with very poor prognosis and with very rapid deterioration of the patient and death from the disease complications. Systemic metastases have very poor response to chemotherapy. Indeed, vulvar cancer is a non-chemosensitive tumor. So, vulvar cancer is a non-chemosensitive tumor. Melanoma. Vulvar melanoma represents 5% of vulvar cancer, and it's not related to UV exposure, obviously. Generally, it's located to the upper periclitoral site of the vulva or to the small labia of the external genitalia. It is microstaged in a different way by pathologists. The depth of invasion is defined by the levels of Clark, of Chang, or with the index of Breslow, according to the habits of the pathologists and according to the guidelines of melanoma treatment. These criteria are not measured only in millimeters, but they take definitions according to the skin appendix present and involved by the tumor itself, that is, the skin, glands, and other structures present in the stroma. So we don't measure these criteria only in millimeters, but also according to the structures present. Treatment of vulvar melanoma is a wide excision of the single lesion or a wide radical excision with lymphadenectomy of the groins. Adjuvant therapy protocols include the use of interferon alpha 2b, but with very poor response rates. When the disease extends outside the vulvar area and becomes systemic, chemotherapy is quite ineffective. Also here, chemotherapy, when there is wide involvement outside the vulvar area, chemotherapy is not effective. And then vaginal carcinoma. Vaginal carcinoma is even rarer than vulvar cancer as a primary site of cancer. In more than 85% of cases, a vaginal cancer is secondary to cervical, uterine, colorectal, ovarian, or vaginal primary tumors. In other site, primary tumors. So usually it's a metastasis. This is the reason why a great debate is still present to understand if a primary vaginal cancer really exists and can be identified as a primary genital tumor. Histology: squamous cell carcinoma represents 85% of cases, clear cell carcinoma 10% of cases, sarcoma 3%, and melanoma 2%. An historical association for clear cell carcinoma is present with the use of diethylstilbestrol in women during pregnancy between 1949 and 1971. Anyway, nowadays this is no more used because there is this association. Etiology: vaginal cancer mimics cervical carcinoma as far as it concerns the relationship with HPV 16 and 18. It has the same natural history, the same risk factors, and the same epidemiology. Staging: Stage 1 is confined to vaginal wall. Stage 2 is stromal, subvaginal tissue involvement but no extension to the pelvic side wall. Stage 3, extension to pelvic side wall. Stage 4, extravaginal extension. Stage 4A, involvement of bowel or bladder. And Stage 4B, distant metastasis. How do we treat? Treatment is based on surgery with radical hysterectomy and partial colpectomy, or vaginectomy for Stage 1. All other stages require radiochemotherapy. So, radical hysterectomy and partial colpectomy or vaginectomy for Stage 1. All other radiochemotherapy. Survival: 5-year overall survival rates are very poor for late disease. The important element of vaginal cancer is that it is arguable that it represents a primary entity, while in almost 85% of cases, it is more of a secondary manifestation of a genital or gastrointestinal disease, as said.